Hello, welcome again. Welcome back to Concepts of Care for Patients with Muskuloskeletal Condition. This is part 2, osteomyelitis. So osteomyelitis is an infection in the bony tissue. We're going to start with the video to understand this condition. Osteomyelitis is the infection of the bone. There you go. There's no audio in this video, so probably I'm going to read whatever appears. Usually the bacteria causes infection in the bone. Leukocytes are attracted to the area and secrete enzymes in an attempt to kill the bacteria. Blood flow to the area is decreased and a devitalized necrotic bone is formed called a sequestrum. A sequestrum is infected dead bone resulting from osteomyelitis. So it's a very shaped, identified area. Harvation canals surround blood vessels and nerve cells throughout the bone. The sequestrum has no connection to normal bone through the harvation system. Therefore cannot supply normal blood or immunoglobulins, right? Due to the avascular nature of the sequestrum, antibiotics cannot reach the sequestrum or the bacteria because the sequestrum is separate from the harvation system. In fact, the bacteria enters the bone cells and hides inside the bone cells, so antibiotics are not helpful. The involucrum is new bone formation around the sequestrum. The body is trying to seal off the infection by forming this. The sequestrum will drain through the sinus. There's a little canal formed in the bone to the outside. Biopsy of the sinus is not representative. Multiple deep samples are needed. Biopsy of the sinus is important in long-standing cases of myomyelitis to rule out squamous cell carcinoma. So they need to open the involucrum in order to do a surgical procedure, remove the sequestrum, that tissue that is well-shaped, saucerize the bone, make sure a pathological fraction isn't created when they do this surgery, and stabilize if needed. Fill cavity with bone chips, cement, and muscle flap if needed. Antibiotic usually for 6 weeks, and recurrence is high, about 30%. Very good. So basically, this is the osteomyelitis. This was a presentation. We see that osteomyelitis is an infection of the bone, and we saw that in this case, osteomyelitis could be caused by bacteria, viruses, parasites, or fungi. Okay, so this inflammation produces an avascular type of tissue that is called sequestrum. It's an amount of cells inside of the bone that they get separate from the harvation system. So there's no way blood or these white blood cells can attack, and neither the antibiotics can get in. Okay, so osteomyelitis may be categorized as exogenous, in which infectious organisms enter from outside of the body, as in an upper fracture or after a surgery, or endogenous, hematogenous, in which organisms are carried by the bloodstream from other areas of infection in the body. A third category is contagious, in which bone infection results from a skin infection of adjacent tissues. Osteomyelitis can be further divided into two major types, acute or chronic. So in the first case, in the first scenario, which is exogenous, is because there is an opening from outside that is going to invade the bone. It could be a fracture, a surgery, and is endogenous when the organisms are carried by the bloodstream from other areas, right? Acute hematogenous infections result from bacteremia, underlying disease, or non-penetrating trauma. Urinary tract infections, for example, particularly in older men, tend to spread to the lower vertebrae. Long-term IV catheters can be primary sources of infections. Patients undergoing long-term hemodialysis and IV drug users are also at risk for osteomyelitis. Salmonella infections of the GI tract may spread to bone. Patients with sickle cell disease and other hemoglobinopathies have often have multiple episodes of salmonellosis, which can cause bone infection. So this is good to know. They just describe how the acute hematogenous can be caused. But also I will add, just because they mentioned the long-term IV catheters, I will add the patients that are receiving chemotherapy and they have a port right next to the clavicle or below the clavicle, sometimes on the right side, which is most common, and they receive the chemotherapy there. So these are placed there for a long time. Also, poor dental hygiene and periodontal gum infection can be causative factors for contiguous osteomyelitis in facial bones. What is contiguous again? The bone infection results from skin infections or adjacent tissues. So in this case, minimal non-penetrating trauma can cause hemorrhages or small vessel occlusions leading to bone necrosis. Many infections are caused by Staphylococcus aureus, and this is the big one in hospital. Staphylococcus aureus is the amount of infections is amazing, okay, and it's really it's very dangerous. So most of the patients, some patients that they believe they are going to stay in the hospital for 1 month, 2 months, and they feel safe there, get out from the hospital as soon as possible. Staphylococcus aureus treatment of infection may be complicated further by the presence of methicillin-resistant Staphylococcus aureus, well known as MRSA, or other multidrug resistant organisms, MDRO. MRSA in patients with musculoskeletal health problems are post-operative surgical site infections and infections from surgical implanted devices such as an open reduction internal fixation device. So the most common cause of MRSA in patients with musculoskeletal health problems are post-operative surgical site infections, okay? And infections from surgical implanted devices such as an open reduction internal fixation device. That is why it's so important to wash your hands, to have your uniform clean, neat, have short nails, because all these bacteria can hide below the nails, you know. Wear your gloves. Just to let you know, you need to protect yourself. The most common cause of contagious spread in older adults is found in those who have slow healing foot ulcers. The slow healing foot ulcers, basically those patients that are in bed your diabetic patients. Okay. Penetrating trauma leads to acute osteomyelitis by direct inoculation. Animal bites, puncture wound, skin ulceration, and bone surgery can result in osteomyelitis. The most common offending organism in these cases is Pseudomonas aeruginosa, but other gram-negative bacteria may be found. Dr. Matalana, what is Pseudomonas aeruginosa? But where can I find Pseudomonas aeruginosa, right? So we want to know exactly where can this be found. And this is a nurse safety alert. Pseudomonas aeruginosa lives in the environment and can be spread to people in healthcare settings when they are exposed to water or soil that is contaminated with these germs. Resistant strains of the germ can also spread in healthcare settings from one person to another through contaminated hands, equipment, or surfaces. There you go. Okay, so nurses, go to your shift. You finish your shift, you wash your hands, go home, change your uniform, change everything, and wash everything. Okay, because you are bringing home a lot of bacteria, and it's not worth it, right? To try to work in an environment to provide care to patients, and then you end up being the one sick. If bone infection is misdiagnosed or inadequately treated, chronic osteomyelitis may develop, especially in older adults who have foot ulcers. Okay, inadequate care management results when the treatment period is too short or when the treatment is delayed or inappropriate. Okay, let's talk about assessment. In osteomyelitis, bone pain, often described as a constant localized pulsating sensation that worsens with movement. Oh, I cannot believe the amount of pain. You wouldn't believe the amount of pain I've seen in patients with osteomyelitis. Older adults may not have an extreme temperature elevation because of a lower core body temperature and compromised immune system that occur with normal aging. In general, your older adults, you need to monitor for everything from urinary tract infection, at home, in the hospital. They are not going to complain. They are not going to tell you, I have fever. You need to be next to them and do your proper assessment. Fever, swelling, and erythema, hyperpigmentation are less common in those with chronic osteomyelitis. It's like the body is getting used, right, to this type of adverse environment. When vascular compromise is severe, patient may not experience pain because of nerve damage from lack of adequate perfusion. It's like the diabetic, right? When they have neuropathies, they don't feel the hot water, they don't feel the cold water, right? When vascular insufficiency is suspected, assess circulation in the distal extremities. When vascular insufficiency is suspected, assess circulation in the distal extremities. Ulceration may be present on the feet or hands, indicating inadequate healing ability as a result of impaired perfusion. Elevated white blood cells, leukocytes count is going to be found in the blood work, which may be double the normal value. Okay, so if your normal white blood cells are 4 to 11, it's not difficult to think you're going to see WBCs on 31, 40. Okay. The erythrocyte sedimentation, ESR, may be normal early in the course of the disease, might be rise as the condition progresses, and we know that ESR is always testing inflammation. It may remain elevated for as long as 3 months after drug therapy is discontinued and can be used to monitor the effectiveness of the treatment. So ESR is going to be elevated 3 months after. So if the patient finishes treatment in January, ESR is going to be elevated until April. Key features are acute versus chronic osteomyelitis. You see acute osteomyelitis, fever. It's going to be swelling around the affected area, possible erythema, hyperpigmentation, tenderness of the affected area, bone pain that is constant, localized, and pulsating, worsens with movement. This is very important. Oops, what happened here? And then we are having the chronic osteomyelitis, in which you are not going to see fever, no swelling, no erythema, hyperpigmentation, which are less common in this stage. But you're going to see foot ulcers or bone surgery. They are going to practice bone surgery most commonly. Sinus tract formation, and they have to do because it's chronic, right? They have to do it. Sinus tract formation, which means the bone creates a little pathway to the outside and start the draining, right? Draining. Localized pain, drainage, exactly, from the affected area, usually due to bone abscess. So this is the chronic. And probably, and I dare to think that since you are draining the pus, right, the infection, that's why also there's no fever, because you are kind of getting rid of those of that bacteria, right? Could be a reason. I'm just thinking. Bacteria in the bloodstream that could lead to septic shock, right? If the bacteremia happens, right, there's going to be septicemia, septic shock. Blood culture identifies the offending organism to determine which type of antibiotics should be used in treatment. Okay, so in septic shock, the triad is fever, low blood pressure, and high respiration rate, right? Take actions, intervention. Surgical debridement is performed to remove as much of the necrotic and infected tissue as possible. Also, they are gonna use IV antimicrobial therapy based on the wound culture and sensitivity results, of course. In the presence of copious wound drainage, follow contact precaution to prevent the spread of the offending organism to other patients and healthcare personnel. So in the presence of copious wound drainage, this patient needs to be in isolation, period. And every time you enter, you wear your gown and all your protective PPE equipment corresponding to that disease. Some patients may need to be admitted to a skilled nursing facility for IV drug therapy. Okay, I want to add to the previous paragraph that sometimes, due to the shortage of nurses in the country, sometimes one nurse is going to receive a district. District is called the amount of room they are going to give you, right? With the amount of patients. So sometimes your district is going to be 7 or 8 patients. And sometimes in your district, you're going to have 3 different contact precautions, patients with different contact precautions, okay? Droplet precautions, contact precautions, different types of isolation. So you need to be ready, and you need to be mastering your PP, your protective equipment, uniform, okay? Make sure you know what is for each type of precautions, okay? It's very important. That's why if you can be, try to be cleaning, washing your hands in excess is good. It's not bad, it's good. Some patients may need to be admitted to a skilled nursing facility For IV drug therapy for patients with MRSA infection, IV vancomycin, IV daptomycin, or linezolid IV or oral may be used. Okay, so the optimal drug regimen for patients with chronic osteomyelitis is not well established. Prolonged therapy for more than 3 months is typically needed to eliminate the infection. Patients are usually cared for in the home or skilled care setting with long-term vascular access catheter, such as peripheral inserted central catheter. There are also pharmacologic and non-pharmacologic interventions for both acute and persistent chronic pain. A treatment to increase tissue perfusion for patients with chronic and remitted osteomyelitis is the use of a hyperbaric chamber, which is very useful and is very effective, or portable device to administer hyperbaric oxygen therapy. It's really good. But this sometimes the insurance doesn't cover, and sometimes what the patient wants to pay from its pocket is very expensive. Bone tumors. Let's continue. Pathophysiology review. Bone tumors may be classified as benign, non-cancerous, or malignant cancerous. Benign bone tumors are often asymptomatic and may be discovered on routine X-ray examination or as the cause of pathologic fractures. The cause of benign bone is not known. There are too many diseases that so far, with all the technology and advances in medicine, they don't know the reason. That is when we functional medicine practitioners think about the other factors, right? The nutrition, the level of stress, the energetic influence from different sources in human bodies. So give it a second thought. The most common benign bone tumor is the osteochondroma. Chondroma relates to cartilage. Do you remember chondroitin when we were studying the first chapter of the musculoskeletal system? We were talking about some supplements, glucosamine chondroitin, right? It's very common. It works in the cartilage. Osteochondroma is an overgrowth of cartilage and bone that happens at the end of the bone near the growth plate between epiphysis and metaphysis. So we have the bone is the long part of the bone is the diaphysis, and at the end of the bone we have the epiphysis. But before the epiphysis is the growth plate, and below the growth plate is the metaphysis. So in that part, is where the new cartilage starts growing, and that is osteochondroma. This happens usually in childhood. The tumor grows until skeletal maturity and may not be diagnosed until adulthood. So there may be a single growth or multiple growth and can occur in any bone. So it could happen in one bone or different bones, but always in the same site, right? The femur and the tibia are most often involved. The femur and the tibia are most often involved. So that means the femur is the bone next to the hip, and the tibia is the bone that connects, let's say, the knee to the ankle, right? But in the interior, in the interior. Okay. Malignant cancerous bone tumors may be primary, those that begin in bone, or secondary, those that originate in other tissues and metastasize spreads to bone. So right there you have the difference. The benign bone tumor, osteochondromas, are more related to the cartilage, right? While malignant, they begin in the bone itself. Now, primary tumors occur most often in people between 10 and 30 years of age. and make up a small percentage of bone cancers. As with other forms of cancer, the exact cause of bone cancer is unknown again. But genetic and environmental factors are likely causes. Genetic and environmental is part of our debate in functional medicine. Metastatic lesions most often occur in the older age group and account for most bone cancers in adults. Metastatic lesions. So these elderly patients that are having an immune system that is compromised, it could be for chronic conditions, it could be for medications, it could be because they are aging, right? So the immune system is not as strong as before. They are the ones who are having most metastatic lesions and most bone cancers in adults. Osteosarcoma, okay, is the most common type of primary malignant bone tumor. More than 50% of cases occurs in the distal femur, osteosarcoma in the distal femur, followed in decreasing order of occurrence by the proximal tibia and humerus. Humerus is one of the upper extremities, right, in the arm. The tumor is relatively large, causing acute pain and swelling. Osteosarcoma is relatively large, causing acute pain and swelling. It's usually warm because the blood flow to the site increases. The center of the tumor is sclerotic, and that means that is unusual thickness of the bone. Sclerotic is an unusual thickness of the bone from increased osteoblastic activity. So I'm thinking that probably because the bone is being affected, the the mechanism of defense from the bone, the osteoblastic, starts to create new bone cells in order to repair that damage, and it's not successful, right? That's why there is an sclerotic unusual thickness of the bone. Osteosarcoma typically metastasizes, spreads, which results in death. Osteosarcoma. Now we have Ewing sarcoma. It's not as common as other tumors. It is the most malignant, but it's the most malignant. Ewing sarcoma. It causes pain and swelling. In addition, systemic signs and symptoms, particularly low-grade fever, cytosis, and anemia, are common. So osteosarcoma and Ewing sarcoma, to me, both are malignant, both sound similar. So what we are going to watch now are the comparison, and we're going to try to find the differences between osteo and Ewing sarcoma, okay?
Today's medical-centric topic is osteosarcoma versus Ewing sarcoma.
Ewing.
Similarities and differences. Osteosarcoma and Ewing sarcoma are both types of bone cancers that primarily affect children and young adults. While they share similarities in terms of their origins and impact on bone tissue, they also have distinct characteristics that set them apart. Understanding the similarities and differences between osteosarcoma and Ewing sarcoma is crucial for accurate diagnosis, treatment planning, and improved patient outcomes. In this video, we will explore the similarities and differences between these two types of bone cancer. Similarities between osteosarcoma and Ewing sarcoma. 1. Bone tissue origin. Both osteosarcoma and Ewing sarcoma originate in the bone tissue, although they may differ in the specific bones affected. 2. Occurrence in children and young adults. Both cancers predominantly occur in children and young adults, with peak incidences during adolescence. 3. Aggressive nature. Osteosarcoma and Ewing sarcoma are considered aggressive cancers with the potential to metastasize, spread, to other parts of the body if not treated promptly and effectively. 4. Radiographic appearance. On X-rays and other imaging scans, both osteosarcoma and Ewing sarcoma can present as areas of bone destruction or abnormal growths. Differences between osteosarcoma and Ewing sarcoma. 1. Cellular origin. Osteosarcoma arises from bone-forming cells called osteoblasts, while Ewing sarcoma originates from primitive nerve cells found in bone or soft tissues.
Oh, that's a difference.
2. Age distribution. Osteosarcoma typically affects individuals in their teenage years, whereas Ewing sarcoma has a broader age range and can occur in children as young as 5 years old
Oh, wow.
and in adults. 3. Primary site. Osteosarcoma commonly develops in the metaphysis, the region of the long bones where bone growth occurs, while Ewing sarcoma can arise in various bones, including the long bones, pelvis, ribs, and flat bones, such as the skull.
Okay.
4. Genetic alterations. Ewing sarcoma is characterized by a specific genetic abnormality called EWSR1 FLI1 fusion gene, which is not present in osteosarcoma. This genetic marker helps in the diagnosis of Ewing sarcoma. 5. Histological appearance. Under a microscope, osteosarcoma shows malignant bone tissue with varying degrees of bone formation, while Ewing sarcoma appears as small, round, blue cells with a characteristic
Oh, wow.
onion skin-like appearance. Treatment approaches. 1. Osteosarcoma treatment. The mainstay of osteosarcoma treatment involves a combination of surgery to remove the tumor and chemotherapy to target any remaining cancer cells.
Okay.
Limb salvage surgery may be an option in some cases, while amputation may be necessary in others. 2. Ewing sarcoma treatment. Ewing sarcoma is typically treated with a combination of chemotherapy, surgery, and radiation therapy.
Yeah, that's another
The specific treatment approach depends on factors such as tumor location, size, and the presence of metastasis. Osteosarcoma and Ewing sarcoma are aggressive types of bone cancers that primarily affect children and young adults. While they share similarities such as bone tissue origin, occurrence in younger individuals, and aggressive nature, they also have distinct differences in terms of cellular origin, age distribution, primary site, genetic alterations, and histological appearance. Recognizing these similarities and differences is crucial for accurate diagnosis and appropriate treatment planning. A multidisciplinary approach involving oncologists, orthopedic surgeons, and other specialists is essential to provide the best possible care for individuals affected by these challenging cancers.
Thank you for watching our video. Please do not
Thank you so much. It was a very good video, the comparison. So, the Ewing sarcoma originates on the cells that are the nerve cells related to the bones, versus osteosarcoma is more related to the metaphysis, right? And then osteosarcoma is going to develop in the femur, at the end of the lung bones, while Ewing sarcoma is going to develop even in the brain, right? In the bone of the brain, the cranial. And also genetic presence in Ewing sarcoma. Osteosarcoma does not have the genetic, and the histological appearance. The Ewing sarcoma is round, blue shape, and the osteosarcoma is, you can see the bacteria there. Impressive. Okay, so let's assess for pain, the most common symptom of most bone tumors, and especially with movement, right? Direct tumor invasion into soft tissue, compressed peripheral nerves, or a resulting pathologic or fragility fracture. That's why the pain is caused by that, the direct tumor invasion. Severe unrelenting pain is the primary concern for patients who have metastatic bone disease, particularly when the patient moves. And these patients that are having metastatic, they are receiving palliative care. And a lot of opioids and medication for pain, and probably they are most of the time sedated, right? When the tumor affects the lower extremities or the small bones of the hands and feet, local swelling may be detected as a tumor enlarges. Muscle atrophy or muscle spasm could be present. Marked disability and impaired mobility may occur in those with advanced metastatic bone disease. And that's good to know, right? That's good to know. Okay, so what types of imaging that provider is going to order? Probably routine x-rays are used to find bone tumors and bone metastases. CT and MRI are useful for complex anatomic areas such as the spinal column and sacrum. And in some cases, a needle bone biopsy may be performed, usually under fluoroscopy to guide the surgeon. Needle biopsy is an ambulatory care procedure with rare complications. It's true. After biopsy, the cancer is staged for size and degree of spread. One popular method is the TNM system, and this is good to know. Alert, alert, NCLEX alert. Based on tumor size and number, the presence of cancer cells in lymph nodes and metastasis spread to distant sites M, right? So basically, you can see a question in NCLEX like this. A patient with bone cancer is a stage T3, M4, M2. So what is the meaning of T3 and they are going to start giving you the options, right? T3 stands for 3 lymph nodes involved, which is not the case because N is the one with lymph nodes. And so and so. Okay, so you need to know this TNM method system. The patient with a malignant bone tumor typically shows elevated serum alkaline phosphatase. What happens, let me complete the comment before. The TNM, the stage, is going to guide the nurse and the providers on how the care, what type of care the patient needs. Okay, so if it's a patient that is having a lot of lymph nodes involved, okay, so then probably they are going to put the patient in isolation risk for blah blah blah. Okay, because the tumor is doing a lot of metastasis, okay, and probably they are putting the patient in ICU. They want to know where the metastasis is. They are going to order PET scans. They are going to see if the liver is compromised, if it's something that is compromised in the spine or the heart, different types. So this TNM system is giving you the idea of what type of care the patient is going to need. The patient with a malignant bone tumor typically shows elevated serum alkaline phosphatase. We spoke about this marker, let's call it this way, in the previous chapter, okay? Indicating the body attempt to form new bone and increasing osteoblastic activity. So alkaline phosphatase belongs to one of the 3 liver enzymes, your AST, your ALP, okay, and your ALT. So this one is in reference to bones, okay, and is indicating the body attempt to form new bone by increasing osteoblastic activity. The patient with Ewing sarcoma or metastatic bone cancer often has anemia and leukocytosis. So increased white blood cells. The progression of Ewing sarcoma may be evaluated by elevated serum lactate hydrogenase LDH levels. And I mentioned before that also this LDH is going to be high with patients with leukemia. It's amazing. There are some patients that are having 3200 LDH level. Okay, in some patients with bone metastasis from the breast, kidney, or lung, the serum calcium level is elevated. Massive bone destruction stimulates release of the mineral into the bloodstream. In patients with Ewing sarcoma and bone metastasis, the erythrocyte sedimentation rate, again, the one that is measuring inflammation, may be elevated because of secondary tissue inflammation. So, NCLEX question, that's good to know. The nurse, I told you last time to start first with the question in the stem of the question. So let's start here. Which assessment finding would the nurse anticipate as the priority problem? So meaning, what is the priority for the nurse to do? Okay? What is the priority to consider? Now we are reading the question. The nurse is assessing an older client with advanced metastatic bone disease. That's it. The patient is having advanced metastatic bone disease. What assessment, what is the most important that I need to check, right, in this type of patient? So are we going to check difficulty with ambulation? Are we going to consider inability to perform ADLs? Are we going to consider nausea and vomiting from chemotherapy or risk for falls due fragility fracture? This is the one. This is the one. It's a metastatic, advanced metastatic bone disease. Let's continue. Interventions. Because pain is often due to direct primary tumor invasion, treatment is aimed at reducing the size of or removing the tumor. Benign or small primary malignant bone tumors are usually completely removed for a potential cure. The expected outcome of treating metastatic bone tumors is palliative rather than curative, of course, and comfort measures, right, for this patient that is suffering for terrible pain from metastatic bone tumors. The following discussion focuses on intervention for patients with malignant bone tumors or metastatic bone cancer. Let's see. So we have the non-surgical management. So in addition to analgesics, a lot of analgesics for local pain relief, chemotherapy and radiation therapy are often given to shrink the malignant tumor. For patients with painful metastatic spinal involvement, bracing and short-term immobilization may be appropriate. So it's a discussion right now going on if these patients having bone tumors, malignant bone tumors, or metastatic bone cancers, if it's worth it to put the patient under chemotherapy and radiation, right? Besides the pain and everything, and considering the consequences, the side effects of this chemotherapy and radiation, having into consideration that this metastatic bone cancer is not going to heal, right? So Ewing sarcoma are sensitive to cytotoxic drugs. Others, such as chondrosarcomas, are often totally drug resistant, right? So Ewing sarcoma is sensitive to cytotoxic drugs, while chondrosarcomas are often totally drug resistant, right? So for specific metastatic cancers, depending on the location of the primary site, for example, they're going to use biologic agents such as cytokine. We spoke about this before. They are sending signals, are given to stimulate the immune system to recognize and destroy cancer cells. So they are cytokines. They are going to signal the immune system to recognize and send the special forces from the immune system to destroy those cancer cells, especially in patients with renal cancer. So zoledronic acid, remember this is given IV, and pandrinated R2IV biphosphonates, we reviewed this before, that are approved for bone metastasis from the breast, lung, and prostate. This zoledronic is an IV biphosphonate that is approved for bone metastasis from the breast, lung, and prostate. This drug helps protect bones and prevent fractures. Although rare, inform patients that osteonecrosis of the jaw may also occur, especially in those who have invasive dental procedure. That's why you need to review your medications, okay? And this is good to know. NCLEX alert. Monitor associated laboratory tests such as serum, creatinine, and electrolytes because these drugs can be toxic to the kidneys and cause acute kidney injury. That's why. For example, so far, we have mentioned different drugs that we need to monitor the liver, like alkaline phosphatase, for example, is a liver enzyme. And right now we are monitoring the kidney, right? So there you go. Two important and major organs that are being involved in this drug management. Denosumab is a I always forget, receptor activator of nuclear factor kappa B inhibitor that is also approved for metastatic bone disease, right? So this type of medication works on regulating gene expression. It's gonna try to cause to make to tell the gene take it easy, right? Take it easy. The drug binds to a protein that is essential for the formation, function, and survival of osteoclasts. By preventing the protein from activating its receptor, the drug decreases bone loss and increases bone mass and strength. And this is good. It's good that we review already several times what are osteoclasts, their activity, what are osteoblasts and their activity. So when we read this information, we are totally familiarized and we understand the extent of the drug management. Radiation therapy. Either brachytherapy or external radiation is used for selected type of malignant tumors. For patients with Ewing sarcoma, let's remember that osteosarcoma doctors usually prescribe surgery and chemotherapy, period. For Ewing sarcoma, they can prescribe surgery, chemotherapy, and radiation. For Ewing sarcoma and early osteosarcoma, radiation may be the treatment of choice in reducing tumor size and thus pain. Well, that's something different from that we learned, right? So maybe radiation is only used on early osteosarcoma. My understanding was that it was only Ewing sarcoma. For patients with metastatic disease, radiation is given primarily for palliation. Okay. Now, there is another type of treatment. It's called microwave ablation. MWA can be done under moderate sedation or general anesthesia to kill the targeted tissue with heat by using microwaves. They forgot that microwave, they also have radiation in it, right? Most patients have pain relief or control after this ambulatory care procedure. Surgical management for this type of bone cancers. Primary malignant bone tumors are usually reduced or removed with surgery, and surgery may be combined with radiation or chemotherapy. Yes. Wide or radical resection procedures are used for patients with bone sarcomas to salvage the affected limb. Wide excision is removal of the lesion surrounded by an intact calf or normal tissue and leads to cure of low-grade tumors only. A radical resection includes removal of the lesion, the entire muscle, bone, and other tissues directly involved. It is the procedure used for high-grade tumors. And this type of surgery, this radical resection, in which they are removing the lesion, the entire muscle, is the one that make me get in contact with the surgeon when I was a PCA, when the surgeon came to ICU to take care of this patient post-surgery. He was asking for the nurse, and the nurse was not in the floor. He needed help. He needed somebody to help him change the dressing. And he found me in the middle of the floor. He asked me if I can do this. And he told me the situation. He told me hope you don't faint because the incision, the wound is impressive. So when he saw me that I was naturally helping him and was handling the situation and controlling myself, he decided to write a letter for me for the nursing school. So because of this doctor, I decided to go for nursing. In some cases, an allograft may be implanted with internal fixation for patients who do not have metastasis. This is a common procedure for sarcoma of the proximal femur. Operative chemotherapy, right, is given to enhance the likelihood of success. So there is a video talking about allograft that I want you to see, because it's unbelievable how they are able to replace a piece of bone with such a perfection. This is to have an idea, right? Doesn't mean
The allograft oat system for cartilage restoration allows for the efficient treatment of large, symptomatic lesions of osteoarticular surfaces. Following preoperative examination to confirm the size of the lesion, perform a standard parapatellar arthrotomy to expose the defect. Select the appropriate cannulated allograft oats sizer to estimate and approximate coverage of the lesion. Place the sizer used to establish the recipient defect size over the allograft condyle to ensure the allograft is large enough for the defect site. Then, mark it circumferentially and add a reference mark in a superior 12 o'clock position. Once the appropriate size match has been confirmed, return to the recipient site and place the sizer over the defect, staying perpendicular to the condyle surface. Advance a drill tip guide pin through the sizer into bone. Create a circumferential mark around the cylinder. Remove the sizer and place a reference mark in a superior 12 o'clock position. Assemble the appropriately sized recipient scorer with the Quick Connect T-handle and 2.4 mm guide pin. Then use it to score the articular cartilage to the subchondral bone. Select the appropriate recipient site reamer and loosen the wing nut. Advance the reamer to the desired depth of the recipient site and secure the wing nut. Secure the recipient site reamer with depth stop to the drill and place it over the drill tip guide pin.
Wow.
Drill the counterbore into the defect to the desired depth, typically 5 to 8 millimeters. Confirm bleeding subchondral surfaces. Thread the appropriately sized allograft oats dilator onto the slap hammer and insert it into the recipient's socket site to achieve a 0.5 millimeter socket dilation. Advance the dilator until it has seated fully into the socket. Take depth measurements of the created socket from 4 quadrants and record them for use when creating the allograft core. Secure the donor allograft in the allograft oats workstation. Place the appropriately sized allograft oats workstation bushing into the articulating arm housing. Move the articulating arm over the graft and set the exact angle necessary to match the recipient's contour. Use the oat sizer to confirm you are perpendicular to the graft. Securely fasten the housing using the hexagon bolt and cheater bar. Connect the allograft oats donor harvester with a collared guide pin to a drill and pass it into the proximal graft housing to rest on the graft's surface. Drill the harvester to a depth of 15 millimeters to 20 millimeters and then remove it. Advance a sagittal saw perpendicularly through the condyle at the approximate depth of the reaming and continue until the core releases. An alternative method would be to ream through the entirety of the allograft and use the collared guide pin to gently extract the graft. Mark the depths recorded from the recipient socket on the 4 quadrants of the graft. Then, draw a circumferential mark on the bone. Secure the graft in the allograft oats holding forceps and use a saw to slowly trim it to achieve the appropriate length of bone to ensure a press fit in the recipient socket. Bulletize the graft with a rongeur to assist with insertion. The allograft bone may be soaked in autologous conditioned plasma prior to implantation. A thin layer of demineralized bone matrix, DBM, may be applied to the recipient socket to make slight adjustments as needed. Match the graft reference mark with the recipient reference mark for orientation. Advance the graft with firm pressure into the socket. A tamp may be used as needed to achieve complete insertion. Advance the graft until flush with the surrounding cartilage.
Wow. Unbelievable. There is no way, there is no margin of error, right? Because it's a donor. The unique piece of that is being donated for this purpose. So everything must be perfect. The surgical incision for a limb salvage procedure is often extensive. The patient who has undergone a limb salvage procedure has some degree of impaired physical mobility, such as self-care deficit. So also we have after upper extremity surgery, the patient can engage in active assistive exercise by using the opposite hand to, to help achieve motions such as forward flexion and abduction of the shoulder. Continuous passive motion using a CPM machine may be initiated as early as the first operative day for either upper extremity or lower extremity procedures. After lower extremity surgery, straightening the quadriceps muscles by using passive and active motion when possible. Maintaining muscle tone is an important prerequisite to weight bearing, which progresses from one touch or digital weight bearing to full weight bearing by 2 to 3 months after surgery. The patient who has had a bone graft may have a cast or other supporting devices for several months. Weight bearing is prohibited until there is evidence that the graft is incorporated into the adjacent bone tissue. So basically, I just presented to you the different types of surgeries for the patient. We are not getting into nursing care, but it's good that you are familiarized what is done. Care coordination and transition management. After medical treatment for any type of primary bone tumor, the patient is usually managed at home with follow-up care. When home support is not available, the patient may be admitted to a long-term care facility for extended or hospice care. Evaluate the patient's home environment for structural barriers that might hinder mobility in the case the patient goes home. Because the patient with metastatic disease is susceptible to pathology fractures, potential hazards that maybe contribute to falls or injury should be removed. And in general, we need to train the family members to take care of this patient and to teach them about any adverse events and also the different organizations that are available to help with information. Medical aid in dying, metastatic bone cancer, which is has severe unrelenting pain. There are some, this is information that I am presented to you so you know. There is the assisted death. I forgot the name. Assisted. Okay. So there are some patients that because they are having the metastatic bone cancer, they require to be assisted to have to die, right? With proper medications, with analgesics, opioids. So 10 states, including the District of Columbia and 9 countries, currently have legalized medical aid in dying, and we need to avoid being judgmental, right? It's the right of the patient to decide, so we don't have to comment on this. Common orders of the hand, we have the Dupuytren contracture or deformity. It's a slowly progressive thickening of the palmar fascia, resulting in flexion contracture of the fourth ring and fifth little fingers. Remember that, that's good to know. Dupuytren is the fourth and fifth little finger of the hand. The third or middle finger is occasionally affected. By the theory, by definition, Dupuytren is affecting the fourth and fifth little finger, and the cause is unknown. So another disease that causes a no. It usually occurs in older white men, tends to occur in families, is most common in people with diabetes, and can be bilateral. So before presenting the video, the symptoms are inability to grasp objects, inability to lay hand flat on table. That's a good one. That's a good one. Development of hard core buildup of collagen. Okay, so let's watch this video, Dupuytren contracture. We're almost done with these chapters, guys, and it's very interesting, really. Okay, let's see.
Health Break is sponsored by Providence Health and Services, serving Montana.
Dupuytren's contracture is a hand deformity caused by fascia in the palm forming small nodules, which pull fingers into a bent position. Dr. Vincent Lawrence describes how this condition can be treated.
Historically, what we've done is cut out all of that fascia, but it can be risky because there are nerves that go through it and go down into the fingers, and those nerves are absolutely critical to sensation. Even though it's risky, it can be done safely if you proceed carefully and slowly. Also, there's a technique called needle aponeurotomy, where you take basically it's the hypodermic needle, and you are scratching through the skin after you've used some local anesthesia to break up the cords.
A new technique can correct Dupuytren's without a surgery.
Basically, it's an enzyme, collagenase, that breaks down the collagen that makes up the fascia. You inject it into these cords, and then a day or two later, you bring the patient back to the clinic, and you basically just rupture the cords by stretching the fingers out straight.
To find out more, visit montana.providence.org.
Health Break was sponsored by Providence Health and
Thank you so much. So that's good to know that there is this type of treatment that with an injection, which is called collagenase, is a type of enzyme. This structure is going to be broken down, and the patient is going to recover after 2-3 days, right? Okay, so it's the fourth and the fifth finger, okay? And he said that in some cases the surgery is performed, but there is high risk in touching one of the nerves. So now let's move to ganglion. It's a round, benign cyst often found on a wrist or foot joint or tendon. The synovium surrounding the tendon degenerates, allowing the tendon sheath tissue to become weak and distended. Ganglia are painless on palpation, but they can cause joint discomfort after prolonged joint use or minor trauma or strain. And this is more likely to develop in people between 15 and 50 years of age. So it's a broad spectrum of the population. So let's watch this video. Wrist ganglion. So
Put your thumb up in the air. Put your thumb up in the air for me.
this is the type of fluid he's gonna remove.
A little scratch.
He's putting an anesthetic, right? He's numbing the area. And now he's going to, it was almost automatically, right? He didn't wait that much for the anesthetic to work. It was immediately. So now he's pressing in order to remove all the fluid. You can see the fluid. It's like gel.
Before you take out the needle, just let me hold the zoom again to show the gel.
Okay.
Look at that.
Oh, just gel. I mean,
It's like a hand sanitizer.
Just clean.
Yeah.
Unbelievable. So that is the ganglion, the video of the ganglion that we just saw. And let's move to disorders of the foot. The first one is the hallux valgus deformity. Often occurs as a result of poorly fitted shoes, in particular those with narrow toes and high heels. Hey, nurses. Oh, wow. Other causes include osteoarthritis, rheumatoid arthritis, foot and ankle surgery, and family history. Look at this hallux valgus. Well, this is an extreme case, obviously, right? So let's watch a video of the hallux valgus. Okay, here we go. Almost done.
A bunion, known as hallux valgus, is a deformity of the forefoot in which the big toe drifts towards the second toe. The first metatarsal head sticks out medially, appearing as a lump on the inner side of the foot. As the deformity gets worse, the big toe also rotates and slightly elevates so that the remaining metatarsals at the base of the lesser foretoes have more load and become painful. The skin over the bunion is often red and sore, and the joint may feel painful. Movement of the big toe may also be restricted, particularly if there is arthritis in the joint. Bunions generally develop because of a family history. Then stress on your foot, particularly when wearing tight shoes with high heels, will then bring this genetic predisposition to the forefront. A bunion, medically known as hallux valgus, is a deformity of the forefoot in which the big toe drifts towards the second toe. The first metatarsal head sticks out medially, appearing as a lump on the inner side of the foot.
Thank you so much. So that was the hallux valgus deformity. So this is, for example, crossover toe deformity in a patient with hallux valgus. It should be stages, right, or degrees. This would be like a stage 6. It's very dramatic. Okay, so let's move to, let's see. Okay, here we go. I don't know what's going on with my computer today, but we're almost done. It's not responding to my selections. Okay, surgery is a treatment of choice for this valgus correction. The traditional surgical procedure, a simple bunionectomy, involves removal of the bony growth and bursa and realignment to manage pain. If both feet are affected, one foot is usually treated at a time. Surgery usually is performed at a same-day procedure. Be sure to assess neurovascular status and pain control before allowing the patient to be discharged. Check neurovascular status. Teach the patient to avoid full weight bearing until cleared by the surgeon and to wear an orthopedic boot at all times while awake. The healing time after surgery may be 12 weeks or longer because the feet receive less blood flow than other parts of the body as a result of their distance from the heart. Exactly. Some patients experience a return of the deformity in later years. Oh no. The newer minimal invasive surgical procedure, a lapiplasty, involves several small incisions, and this procedure is usually improving stabilization and prevents return of the deformity. That's good. The patient wears an orthopedic boot or shoe for about 2 to 6 weeks and is able to bear weight 2 to 3 days after surgery. That's awesome. So another NCLEX question. The nurse is assessing a middle-aged client immediately after a traditional open right bunionectomy. Which client finding would the nurse report to the surgeon immediately? So we're checking the pedal pulse, right? Swelling is going to be kind of normal. because it's immediately after. 5 out of 10 pain is going to be kind of normal. Right to capillary refill, more than 5 seconds. But the most important is the right pedal pulse +2, because +3 is normal. +2 means that there is a deficit in the pulse. 1 is not normal and 0 is very bad. So I will report +2 pedal pulses. Plantar fasciitis is an inflammation of the plantar fascia, which is located in the area of the arc of the foot. It's often seen in middle-aged and older adults, as well as in athletes, special runners. Obesity is also a contributing factor. Patient reports severe pain in the arc of the foot, and let's watch this video. This is a very, very common condition, plantar fasciitis.
Plantar fasciitis, the quick facts. What is plantar fasciitis? Plantar fasciitis is foot pain caused by a problem with your plantar fascia, the band of tissue that connects the heel and ball of your foot. It's sometimes called plantar fasciosis. Plantar fasciitis is caused by strain, tearing, or wearing out of the tough band of tissue in your feet called the plantar fascia. Strains or tears of the fascia are more likely to happen if you wear high heels, are a runner or dancer, sit all the time, spend a lot of time on your feet on very hard surfaces, have tight calf muscles, or have flat feet or very high arches. Being very overweight or having rheumatoid arthritis can also cause plantar fasciitis or make it worse. To tell if you have plantar fasciitis, doctors will do a physical exam. If they think your fascia may have torn or your pain is coming from another problem, they may do additional tests such as an X-ray or an MRI. To lessen pain and lower the stress on your foot, take smaller steps, don't walk barefoot, avoid jogging and other high-impact activities, lose weight if you're overweight, and do stretches of your calves and feet. Doctors may have you rest and put ice on your foot. Take non-steroidal anti-inflammatory drugs such as ibuprofen, wear a splint at night to stretch the muscle, wear special devices like orthotics in your shoe, do physical therapy, or get corticosteroid injections into your heel. If your pain doesn't get any better, doctors may put a cast on your foot, apply sound waves to the heel to improve circulation and lessen the pain, or do surgery.
Excellent. So that's plantar fasciitis, and if conservative measures are unsuccessful, endoscopic surgery to remove the inflamed tissue may be required. So this is all about this chapter. Mastery questions. The nurse is planning teaching for another client who is at risk for osteoporosis. Which of the following modifiable client risk factors would the nurse consider as part of the teaching plan? Select all that apply. Modifying. Is older age modifiable? No. Corticosteroid for lung disease? Yes. Lack of regular exercise? Yes. Parental history of osteoporosis, is that a modifiable risk factor? No. Postmenopause is not modifiable. And food insecurity, yes it is. So there you go, you have the 3 answers there. Select all that apply, is coming, that's good to know. The nurse is planning care for a client who had an osteosarcoma surgically removed from the left lower leg. What is the nurse priority for immediate postoperative care? Immediate postoperative care. Monitor for symptoms of wound infection immediately. Assess for symptoms of venous thromboembolism. Evaluate neurovascular status in the left foot, or observe the surgical site for bleeding. So neurovascular status is the answer. Okay guys, we have finished this chapter, and see you soon, and let me continue preparing more videos related to musculoskeletal. Thank you for watching.